We're going to talk today about mandibular techniques. And page 63 in your workbook is going to be very important as a reference guide to use for the mandibular techniques. That page is going to show you the structures that are anesthetized, the penetration site, the terminal deposition site, and the amount of anesthetic that we're going to deposit for each of these mandibular injections. For the inferior alveolar nerve block, this is the big one. Our landmarks are the coronoid notch of the mandible, the pterygomandibular raphe, the pterygomandibular depression right in front of that raphe, the occlusal plane of the teeth, 6 to 10 millimeters above the occlusal plane of the teeth, and the contralateral premolar area. Our injection site is going to be determined by taking our thumb, sliding it out firmly onto that coronoid notch, and we're going to look at half of the distance of our thumbnail as our site of deposition, our height of deposition. Our injection site, according to the slide, says height of coronoid notch, 2/3 the distance to the posterior of the ramus, and at the pterygomandibular depression. For a visual, if we slide our thumb out halfway across our thumbnail, if we slide it out straight, halfway across our thumbnail is going to be that position. If we inject high, then gravity is on our side, and if we sit the patient up, gravity will probably still take that local anesthesia to the area, to the inferior alveolar nerve. One of the main reasons that an IA block would be missed is because it's too low. If it's too low and we sit them up, it just continues to go lower. There's a lot of anatomical variations for the IA as well on people. So the variations in where the inferior alveolar nerve is and how much cheek you have to go through to get there, and the location of the mandibular foramen and the lingula, that varies a lot in the mandibular IA injection compared to any of the maxillary injections. So that's another reason why you might not be as successful with an IA. With the inferior alveolar, you're going to arrange the syringe barrel. You're going to come across the arch over the contralateral premolar area. You're going to penetrate the tissue, and as you're going, there are a few drops deposited. You don't have to specifically stop and deposit a few drops. You are going to advance until the bone is contacted. Usually it's 2/3 to 3/4 of a long needle. You will aspirate, turn, aspirate, turn, aspirate, inject. You're going to inject, and then after you've injected about 1/4, you're going to do a slight aspiration and make sure that you still have not contacted any blood vessel. Make sure that you are not injecting into any type of blood vessel. You are going to withdraw the needle slowly, and then you'll be finished. You'll recap your needle, you'll set it aside, and you'll wait for the patient to get numb while you're proceeding on to the long buccal injection. One thing with the inferior alveolar block is you start off kind of coming across the arch from the contralateral premolar area. Sometimes that internal oblique ridge will get in the way, like we talked about in class. So you may have to come a little bit more anterior, sneak in past, and then do a very slow rounding around that internal oblique ridge. If that happens with you, we'll kind of help you and direct you while we're in clinic on your partner. The inferior alveolar nerve block, you're going to pass by the lingual nerve. So this is the one where there could potentially be a lingual shock because you inadvertently passed near or touched the lingual nerve on your way to giving the inferior alveolar nerve block. There are 7 different things that get anesthetized from the IA. The facial gingiva of the mandibular anterior teeth and premolars, all of the teeth to the midline, skin of the chin, lower lip, mandibular teeth, all of them, lingual gingiva of the mandibular teeth, floor of the mouth, and anterior 2/3 of the tongue. With this injection, the only thing that doesn't get numb is the posterior gingiva on those molars, molar gingiva, interproximal and facial gingiva. The long buccal or the buccal nerve block is usually given right after the IA. So you give 7/8 of the cartridge for the inferior alveolar, and then you use that other 1/8 of the cartridge for the long buccal. Your landmarks are the mandibular molars, the mucobuccal fold, and the retromolar pad. You're going to penetrate the tissue in the mucobuccal fold area adjacent to the second molar or the last molar area. You are going to kind of be looking for that buccal fat pad, advancing the needle just a few millimeters. Sometimes you hit bone almost right away, so you want to make sure the bevel's towards the bone and that your bevel is covered. Sometimes only the bevel's covered, and that's okay. You're going to aspirate, and then you're going to inject slowly. For the long buccal, the facial gingiva of the mandibular molars and the skin of that cheek will be numb. You're only going to go in 2 to 3 millimeters, and then that last 1/8 of the cartridge is what you're going to use on the long buccal nerve block. And you can see there in the picture that it's just the facial and interproximal gingiva of the mandibular molars. Your mental nerve block. Your landmark, remember when we talked about the mental and the incisive being the same location as far as injection site. The mental is the one where we're just going to inject and not massage, or not massage, so diffusion of the anesthetic goes towards the incisive branch of the IA. The mental is just inject and nothing else. Landmark, mandibular premolar, you're going to feel between the molar and the canine. Your site of deposition is going to be the mucobuccal fold, border of the mandible. You're going to go 3 to 5 millimeters in that area once you find the mental foramen. You're going to feel from the molar to the canine. It's usually between the first and second premolar, but not always, so make sure you palpate and feel. The injection target is the mental foramen. You're going to palpate for the foramen. You're going to advance the needle. Here it says about 5 to 6. On our sheet that we have, it says 5. Aspirate, and inject slowly. This is the second most common mandibular injection to have a hematoma appear. So we want to make sure that we aspirate. For the mental nerve block, we are going to have the facial gingiva of the mandibular anterior teeth and first premolar, the skin of the chin, and the lower lip only. So no teeth with the mental nerve block. The incisive nerve block is the exact same technique, exact same spot, exact same distance of penetration, but we are going to continue to apply pressure to the area, and that will enhance the anesthesia to diffuse through the mental foramen and come in contact with the incisive branch of the inferior alveolar, and it will numb from the premolar to the midline of the mandibular anterior teeth. So it will numb the facial gingiva and interproximal gingiva of the mandibular anterior premolars. It will numb the skin of the chin, skin of the chin, the lower lip. So I see I did that, combined chip and lip, or chin and lip for chip, haha. The incisive will numb facial gingiva of the mandibular anterior teeth and premolars, skin of the chin, the lower lip, and the teeth. The difference between the incisive and the mental is the incisive, once you've massaged the anesthesia through the mental foramen, is it additionally numbs the teeth. Interseptal is right in between the interseptal fibers of the teeth. So you're going to achieve soft tissue anesthesia in just a localized area. Typically, you might have this in just one spot where somebody is really sensitive. Maybe you're in a really deep area. You can do it. We'll see you in clinic.